Shonda?
Yeah, she emailed me.
Oh.
Okay. Ready? Are you ready, Miss Ma'am? All right. So let's finish chapter 52. Have you guys learned about BPH?
Yeah. No.
She says that a lot. She says that a lot. Well, benign prostatic hyperplasia is not a complex care disease. But when we, and if you guys could please turn on your cameras, other than the two people that messaged me that said they couldn't, I would really appreciate it. So when we talk about hyperplasia, hyperplasia is the overgrowth of cells, okay? Benign meaning that it's non-cancerous. So what happens is the cells within the prostate get bigger and bigger and bigger. And we talked about on Tuesday how the urethra goes through the prostate. So if the cells of the prostate are getting bigger, it's going to squeeze the urethra, making it constricted. So it's going to be more difficult for urine to pass through. Now, can this happen with cancer, like prostate cancer? 100% yes. But this is specifically benign prostatic hyperplasia. Okay. So enlargement of the prostate gland that surrounds the urethra, it is very uncomfortable. Men, by the way, men are the only people that have prostates. People that are born biologically male have a prostate. And that swelling or overgrowth of, and I have to say that because I have had my first class literally did not know that women did not have a prostate. So I feel like I have to say that to make sure that everybody is aware that women do not have prostates, okay? The swelling and the constriction of the urethra is going to cause difficulty in initiating urine and also getting all of it out. So you're going to see a lot of urinary retention when it comes to BPH. It's very uncomfortable. So if you talk to these men that have a history of BPH or they're really suffering with BPH, they'll tell you that they get up multiple times during the night to urinate because the bladder is always sensing fullness because they can't empty. This is also another reason why men get UTIs or cystitis, inflammation of the bladder. And it's because, remember, we talked about women are more at risk for UTIs because of the short urethra. Well, men don't really ever get UTIs. And the only time they do is when there's obstruction, when there's urinary retention. And if they're putting things in their urethra that aren't supposed to be there. Now, this could be medically, like a catheter. Or this could be, I'm not yucking anybody's yum or, whatever. But like, there are people that stick things in their urethra because they want to feel something from it. Whatever. It is what it is. Am I losing you guys? My screen just went weird.
Your screen share cut out for a second, but it's back.
Yeah, no,
Okay.
You're good.
Okay. So when people stick things in their urethra, we need to educate them. Not that they aren't allowed to. They can do whatever they want with their bodies, but they need to do it in a clean, aseptic, or sterile technique. Okay. There are two classes of drugs that assist in these symptoms. You have alpha adrenergic blockers, and you have drugs that block the conversion of testosterone. So your most common medications on this list, doxazocin. By the way, every time I read this word, it makes me think antibiotic. It's right, zocin, doxazocin. It just feels like an antibiotic. It's not. So don't get confused. Doxazocin is not an antibiotic. It is an alpha adrenergic blocker. You will see this sometimes. Tamsulosin, which is Flomax, that is one of the most common of these medications, for sure. And then these two down here, finasteride, finasteride is going to be your most common testosterone blocker. So adrenergic blockers, that means that it is blocking your adrenergic hormones. Adrenergic are male hormones, okay? And then the second one where it's blocking the conversion of testosterone. So both drugs are stopping testosterone in some way. One is blocking the way it's made, and one is just blocking it, okay? So the therapeutic actions are going to vary. Indications are really 90% of the time it's going to be for BPH. Sometimes these drugs are used to make it easier to pass kidney stones. And that's really the only time you'll ever see these drugs given to women. Also, by the way, these drugs will never be given to a woman that is premenopausal. Ever. Ever, ever, ever.
It's for prostate.
They can be given to women, but they have to be post-menopausal, after menopause. Okay? And it's actually just become a little bit more popular within the last couple of years. When I was in nursing school, this was a hard no. Women never received these medications. Okay? Also, one of the most important things that I need you to know about this drug, and I need you to write this down, and I need you to put a big fat star on it and highlight it, because not only do I want you to know it for your exam, I want you to know it for the rest of your career. You, as minus my guys here, as childbearing females that are premenopausal, cannot touch these drugs with your fingers, with your hands. You cannot touch them. When you take this drug, what? What'd you say? Maybe? Okay. When you take this drug out of the Omnicell or Pyxis or whatever, a thing will pop up and it says, caution, PPE required. Okay? For all of them. All of those drugs. Every single one of them. Because they can get into your skin and they can put you at risk. They can cause trauma to your fetus if you have one, and will put you more at risk for lovely cancers that affect our female reproductive organs. Okay, so if we were at clinical, if we were at work and you said, Jess, I just found out I'm pregnant, you're not even going to be looking at this drug. Somebody else is going to be passing this drug for you. If
This is tamsulosin?
Tamsulosin,
Or both of them?
This is all of those drugs. Every single one. I mean,
because my dad's on both, and I fill his pill reminder with bare hands every week. So,
Please don't do that.
I never knew that. I didn't know that.
I can almost guarantee you it says it on the side of the bottle. Really?
No, I have been filling his pill reminder for 5 years straight, and he's on Finish Straight and tamsulosin, and it says a lot of things on that bottle, but that never ever. And then when I work at facilities and I'm passing it, it's never popped up on at least point click care that it was you had to use PPE.
So I don't have a lot of experience in long-term care or nursing homes, but every Omnicell I've ever used, when I take those drugs out, it will pop up and say caution PPE. So please put gloves on when you handle other people's medication, always, even if they're your loved one, because I don't want anything bad to happen to you. And I don't want you to be more at risk. So it's very important that you know this.
I got a
Like
question.
I said, yeah, go ahead.
Is it just for Tamalosa or is the whole drug class?
It's for the entire classification of both classification of drugs.
Oh, okay.
I just Googled it. It just said the ones, which is the femicide and the duotericide, not the translucent you could handle with your hands.
Both of them pop up with a PPE precaution. And I'm just telling you what is the right thing to do. Okay. So you need to be cautious handling these drugs with your hands, and make sure you are wearing gloves whenever you're passing medications. Okay. So obviously a contraindication would be allergies to the drug. You want to use caution in patients that have hepatic or renal dysfunction. Adrenergic blockers, they can have an effect on heart failure and known cardiovascular or coronary disease. So you want to be cautious with patients that have heart failure and coronary artery disease. You also want to be cautious when you look at drug-to-drug interactions. So antihypertensive, nitrates, erectile dysfunction drugs. What? Did you have a question? Okay. Because these drugs dilate, if you give them with other drugs that cause dilation, like nitrates and like Viagra and some antihypertensives, you can cause even more vessel dilation, causing hypotension. Okay. Saw palmetto is a over-the-counter thing that you can just buy at like Walmart, right? Herbal supplements. You want to be careful with herbal supplements, specifically saw palmetto for the testosterone blockers. So, what? It doesn't have that stuff listed, right? No, that's why I'm telling you. This is just taking a closer look at doxazosin. So it says that it results in dilation of arterioles and veins and relaxation of the sympathetic effects of the bladder and urinary tract, which is why it can cause hypotension if you add it in with nitrates or drugs for erectile dysfunction or antihypertensives. So headache, fatigue, dizziness, postural dizziness, lethargy, vertigo, these are all going to be caused by hypotension. Okay. Sexual dysfunction, which is a reason why you will see non-compliance with men sometimes. And then this is looking closer at finasteride. This inhibits the intracellular enzyme that converts testosterone. So it can cause impotence, decreased libido, abdominal upset, breast enlargement and tenderness, and gynecomastia. Men don't usually like to develop breast tissue. So when you're looking at a drug that can cause these type of things, you want to make sure you're providing patient education, and making sure that you're having compliance. So that is the end of the urinary stuff. Any questions before we move on to endocrine?
Are we going to go over last week's material at all today?
Last week? You mean like party?
Tuesdays.
Tuesday's material?
I was just left a little confused with the ADH and
Agreed. Yes, we will go over that today. Yeah. I think that was in the people actually. Okay. Let's have a quick recap over Tuesday. So, did I share? No, not share. All right, so this is just a quick recap, especially over chapter 50 when I had when my brain stopped working about ADH and aldosterone. So we talked about the nephron. We talked about how the glomerulus acts as an ultrafine filter. The blood flows through, and then it goes into the tubules for more filtration to take out water, to take out ions, to put them back. We talked about active transport systems for the removal of electrolytes and some drugs. And then we talked about reabsorption too, about how in the tubules we reabsorb water and reabsorb electrolyte ions and essential substances. So we know that the kidneys are regulating body fluids, we balance electrolytes. We talked about sodium. We talked about how sodium is one of the major components of our body's major cations. And it's actively reabsorbed in the proximal convoluted tubule, which we had the diagram of the tubules, right? Okay. And then the distal convoluted tubule is at the end where all the fine tuning occurs with the electrolytes. Aldosterone is produced in the adrenal gland. So it's part of the RAS system, the renin-angiotensin-aldosterone system. It is released into the circulation as part of the diurnal rhythm. It responds to high potassium levels, sympathetic stimulation like that fight or flight, or angiotensin 3, okay? So what happens is that it stimulates the sodium-potassium pump and causes the reabsorption of sodium in exchange for potassium. So it causes us to hold on to sodium, hold on to water, because water follows salt. If we're holding on to the sodium, we're holding on to the water, and we're excreting potassium, okay? We talked about the permeability, and there was a nice picture on our other slides where it showed how the first part of the descending loop of Henle is permeable, and how the other part is impermeable to water. So I really liked that picture because it showed the sodium and how the water flows in and out, and then how it doesn't flow in and out from the ascending loop. ADH. So antidiuretic hormone is important in maintaining fluid balance. It's released in response to, this is where my brain started to malfunction. So a falling blood volume, sympathetic stimulation, which is your fight or flight, and then rising sodium levels. So if it's present at the distal convoluted tubule, the permeability to water increases. So at the end, with all that fine tuning of electrolytes that we saw in that depiction, if it's fine tuning those electrolytes, there's not a lot of water coming in and out, because this is where we're really saying, okay, I need this here and this there and this much sodium and this much potassium. So if it's increasing the permeability to water, then it's helping hold on to it. So it's a counter current mechanism influence, and ADH release allows the body to finely regulate fluid volume. So anti-diuresis. Diuresis meaning I'm peeing everything out. If it's anti-diuresis, then I'm holding on to it, okay? Which is going to make my urine more concentrated because all of my fluid is in my body, not coming out of it, right? And on Tuesday, when we saw that picture and it had like the urine here and then had urine here, and on the left side or right side or whichever screen you're looking at, it said urine concentration, and my brain just went. So if you're holding on to all of your water, you're not going to have a high urine output, which is going to cause your urine to be more concentrated. We talked a little bit about chloride. Chloride isn't as easily influenced as sodium and potassium, but we do still have to maintain a normal level of chloride. And this happens in the loop of Henle and the distal convoluted tubule. It just helps the movement of sodium. Potassium, we talked a lot about potassium. So 65% of potassium is filtered at the glomerulus and then reabsorbed at the Bowman's capsule and the proximal convoluted tubule. So the Bowman's capsule, where the glomerulus is where it all starts. So if 65% is being filtered and then reabsorbed within that Bowman's capsule, not a lot of it is actually going through the entire filtration process. And then 25 to 30% is reabsorbed in the ascending loop of Henle, which is where your loop diuretics work. So we're holding on to most of it at the beginning of the cycle, right? And then right after that, if we're giving loop diuretics and we're causing a huge output of urine, then we're losing that 25 to 30%, which is how we become hypokalemic, okay? And then fine tuning of everything happens in the distal convoluted tubule. If levels are very high, the retention of sodium in exchange for potassium leads to the retention of water and a dilution of the blood volume, which means if my potassium is high, then that means I have a teeter-totter. If this is my potassium, this is my sodium, and my potassium is high, that means my sodium is going to be low. So if my kidneys say, hey, there's too much potassium here, I need to hold on to my sodium. If I'm trying to balance that out and I'm holding on to my sodium, where's my water going? With my salt inside my body. So I'm retaining salt and water. And that is my coping mechanism. And my potassium, my serum potassium, is going to lower automatically because I'm retaining more water diluting my blood. Does that make sense? Okay. We talked about calcium. We talked about how we needed we need vitamin D to be able to use calcium, and that it has to be activated in the kidneys. So we eat vitamin D, we take vitamin D, and then the kidneys have to activate it for our bones to be able to absorb calcium. Okay. This is just another picture of the nephrons, which I feel like we looked at a lot of these on Tuesday. But at least it tells us where and what is happening. And where you're going to lose water and lose a lot of ions. Okay. So this picture is really helpful when you're looking at, okay, where does the water come out? It comes out here in the first loop of Henle, in the first part of the loop of Henle, which is why we lose all that potassium here. Okay. And then when we come back up, we're holding on to our ions and we're holding on to the water that we have because it's impermeable. Our water's not supposed to be coming in and out of here. Okay. And then our distal convoluted tubule is where a lot of that fine tuning occurs of the electrolytes. Okay. So this question is asking the body's mechanism for controlling the volume of body fluid involves the dilution or concentration of the urine. Which, if you really think about it, it's all about water going in and out. So is it true or false? It's true. So if it all depends on water going in and out of your body or reabsorbing and excreting out of your body, then the result of that process is going to be the concentration of the urine. Okay. So if my salt is dumping in my urine, then my water is going to follow and I'm going to have a lot of output. If my salt is being reabsorbed, then my water is going to follow and I'm going to hold it inside. Okay. So if I'm dumping it all, my urine is diluted. If I'm holding all my fluid inside, my urine is going to be concentrated. When you're dehydrated and you're like, I've only peed one time today, your urine is very concentrated. Okay. Do we want to talk more about the RAS system? Or do you feel okay about that? Or would you like to go over it? This is going to be on your final. And I mean, we are talking about it. We're going to cover it on this second. Okay. So your RAS system, which is the renin-angiotensin-aldosterone system, works to maintain blood flow to the kidneys. So when your kidneys feel less perfusion, I'm not getting enough blood, I'm not getting enough oxygen, it kickstarts the renin-angiotensin-aldosterone system. So renin is released when the blood flow or oxygen to the nephrons is decreased. So that's what I mean when I say perfusion. Okay. So this activates angiotensinogen, which becomes angiotensin 1. Angiotensin 1 is converted to angiotensin 2 in the lungs. Okay. This causes vasoconstriction that raises the blood pressure and increases the blood flow to kidneys. So the angiotensin 2 works on the blood vessel to increase the pressure in the hose. Okay. If the pressure in the hose, if the hole is smaller, the pressure is greater. Okay. So angiotensin 2 is converted in the adrenal gland to angiotensin 3, which stimulates the release of aldosterone. Okay. When we have aldosterone, what are we holding on to? And sodium.
Potassium.
Sodium.
Salt and water.
Sodium and water. So aldosterone acts on the distal convoluted tubules to retain sodium and water, which then increases the blood pressure. So all of these acts within the renin-angiotensin-aldosterone system all work to increase the blood pressure. Okay?
Okay, so renin is released.
Renin is released from the liver. Renin
Well,
is
muscular
released.
cell.
Renin is released from the kidneys, which tells the liver to release angiotensinogen,
which then becomes angiotensin 1.
which comes angiotensin 1,
Then it converts to the second one.
which converts to angiotensin 2 in the lungs.
And then it goes to the third.
Then it goes to the arteries and causes vasoconstriction. Okay. Then it goes to the adrenal gland, where it's converted to angiotensin 3 and stimulates the aldosterone.
Okay.
Okay.
Just wanted to make sure.
So liver. So first, renin, kidneys. Kidneys say, I don't have enough blood here. There's not enough blood pressure. Okay. I need more. Renin tells liver, you need to release angiotensinogen. Cool. I'm releasing it. Okay. Then we are converting into angiotensin 1, which goes to the lungs. And the lung says, okay, we need to increase this pressure, so I'm converting you to angiotensin 2. Angiotensin 2 goes to my blood vessel, my artery, and says, you need to get smaller. You need to constrict so that my pressure gets higher. Okay. Which then I go to my adrenal gland and I become angiotensin 3, which releases aldosterone. Aldosterone says you need to hold on to all of your salt and water. And in turn, we're going to raise the pressure.
So if at any point this pressure gets to where it needs to be, does this cycle just stop there, or does it always go through this whole cycle?
That's a great question. I don't know the answer.
Kind of like a continuous, it kind of all works together.
It all works together.
Okay.
Yeah.
It's
It
not
all
like,
works
oh, at step 2, we're good. We can stop now.
Like
Don't-
how long does
Yeah.
the RAS system
we don't
take?
have to go for the
Is it
physical
like
this time.
3 seconds or is it like a whole 30-minute process?
Like maybe the pressure was a little bit low, we get to the lungs, and bam, it's fine. So it stops there. Does it just always?
Well, so you have to also remember that there's such a fine line, like our normal blood pressure is 120 over 80, right? I run 110 over 70, right? So if that's my normal, is my body constantly going into RAS?
Maybe.
Or is it my normal? You know what I mean? Is this just my normal homeostatic state? Right? Oh, this would have been nice. But it's really hard to see, though. It's really hard to see. But it breaks down the whole RAS system if you can kind of zoom in on that and look, because it has very small words. But it's literally just saying everything that we just said. Okay. We talked about erythropoietin coming from the adrenal glands. Do we need to talk about that again? Erythropoietin is going to stimulate the production of red blood cells. How long is the life cycle of a red blood cell? 120 days. C. C? Does everyone agree with C? The answer is C. Vitamin D must be activated in the kidneys to form into a form that promotes calcium absorption. Do we need to go over the normal anatomy of the urinary tract? Ureters going into the bladder, which then lead to the urethra, which then lead to the meatus, which is the opening of the urethra. Okay. We know that the female urethra is much shorter than the male urethra.
This
So we're going to get started with the endocrine system. So the endocrine system, I know that we talked about how cardiac is kind of the hardest one. Endocrine probably comes in second place. And I would say that some people that are really good at cardiac say that endocrine is harder. And it just depends on kind of how your brain works and which one clicks for you and which one doesn't. So the endocrine system works in conjunction with the nervous system, and it's constantly fighting for homeostasis. Everything we do, everything, every second of every single day is fighting for homeostasis. Okay. So the endocrine system is comprised of glands and hormones, and it's constantly saying, I need more of this. Okay, I have enough. Now you can stop. Okay, I need more of this. Okay, that's enough. I don't need any more. Okay, now I need more of this. Okay, it's constant. So, there's an organized group of specialized cells that produce hormones, and these are all of your glands that produce hormones. Okay, your adrenal cortex sits on top of the kidney. Your intestines, believe it or not, produce hormones. Your kidneys, we obviously know that the ovaries produce hormones. The pancreas, insulin is a hormone. The parathyroid, para meaning around. So para is around the thyroid, parathyroid glands. The pineal gland, it's in your brain. The placenta releases a lot of hormones back and forth between mom and baby. The stomach, we have many, many hormones. That is for hunger, satiety when we're not hungry anymore. The testes, obviously, with testosterone. And then thyroid with T3, T4, TSH, TRH. Okay.
What's the word? I never heard.
Satiety. Satiety?
Satiety.
Yeah, like you're satiated, like you've eaten enough where your brain says, I'm not hungry anymore. And guess what? That's why I had 80% of my stomach removed, because mine didn't work. Yeah. Mine just said, give me more food. Or if it did work, it was very quiet and I couldn't hear it. Speak louder, ma'am. Okay. So this just shows all of your endocrine organs, okay? All of the things that all of your hormones work to affect all of these organs, okay? And it lists where they come from, the hormones. So ADH, your antidiuretic hormone, is coming from the kidneys. Oxytocin, which is our love, feel all lovey and warm inside, comes from the breast and the uterus. Okay. If you've ever breastfed, you would know, and if you've ever had nipple stimulation, it does release oxytocin. Okay. And it will cause your uterus to contract. Fun fact. Okay. We have MSH. This is the melanocyte stimulating hormone. We're not really going to look at that one, but this is everyone has melanin unless they're albino, and they are literally lack melanin. And your skin color comes from the amount of melanin. I get spray tans. I put lotion on my body that gives my body color. If you saw my child, he is literally translucent. The poor child, you can see his veins through his skin. Okay. Is he? That's so cool. That's very cool. Very cool. So this is all regulates the color of your skin. Okay. The more you have, the darker your skin can be. Me, not so much.
Mine's broken.
Mine is broken. So, and then we have our ovaries that release FSH, which is your follicle stimulating hormone, and then your LH, which is your luteinizing hormone. And then if you didn't know, I actually did not know until I did IVF for my sweet, sweet translucent child, that the ovary is actually responsible for progesterone. It doesn't come from anywhere else. It comes from the ovary itself. So when your ovary releases an egg, it leaves a little hole, which is called the corpus luteum. Okay. And while you're pregnant, that first 10 to 12 weeks of pregnancy, that you need that progesterone. If you've ever struggled with miscarriage and it's come down to the fact that you don't have enough progesterone, it's because of this little rotten sucker right here. Because it's not giving you enough progesterone to keep the baby inside your uterus. So I had to take progesterone injections straight into the tuchus for 10 weeks. Every single day. It hurt so bad. It was an IM. My husband got really good at it. But that is where your progesterone comes from to keep your baby in your uterus. And when there is no baby in your uterus, this is where it says, oh, no baby. Let's have a period. Yay. Okay.
So that really is the booger.
It is a rotten little scoundrel right there. Okay. It also produces estrogen. Then we have the testes, which obviously testosterone. We have our adrenal gland, which is atop of our kidney, which releases ACTH, which we'll go over. Then we have our thyroid. Our thyroid releases TSH and a couple other T words that we'll go over, thyroxine, something like that. Then we have our breast that releases prolactin. Prolactin is for our milk production. And then we have our bones, which we need our growth hormone for. Okay. So if you have a child or have seen a child that is very, very small and they need growth hormone injections, okay, that is where that comes into play so it can help them grow. And your hypothalamus is really like the guy in charge. Like he's just like controlling all of this. Okay. So hormones are chemicals that are transported in bodily fluids and act on specific target cells. We talked a lot about receptor sites. Hormones work the same way with receptor sites. Okay. You could think of it as a key to a lock. All right. So our cells are surrounded by doors and they all have different locks and they all need different keys. And I need a very specific hormone to unlock that door to get into that cell. Okay. So they're produced in very small amounts and they're secreted directly into the bloodstream. They travel through the blood and they go to those specific receptor sites or doors to unlock them. And they act to increase or decrease the cellular process that they're needed for. Okay. They're always there. Always. It's just, are they normal? Are they too high? Are they too low? It's always going up and down with homeostasis. Okay. We have different chemical structures, proteins and polypeptides. Proteins are also referred to as amino acids. You have steroids and then you have amines. We're not going to focus too much on these, but I will say when it comes to the steroid ones, I will want you to know that they are steroids and that's why they affect the body the way that they do. Okay. So we kind of just talked about this with the keys and the locks. So they act by linking to those receptors. So if it's on the cell surface, then it's unlocking the receptor with it, like on the cell surface. If it needs to get into the cell to do its work, then it needs to first go inside and then unlock a key inside the cell to affect the DNA. Okay. So the hypothalamus is responsible for coordinating everything, basically. So it's the coordinating center for the nervous and endocrine responses to internal and external stimulus. So something outside that's stimulating your body or something inside for homeostasis that's stimulating your hormone production. And it's constantly monitoring, always monitoring. So the response is the coordinating responses through the autonomic, endocrine, and the nervous system. So all three are working together at all times. And we call this the master gland because he really just is in charge of everything. So either this releases the hormone itself, or it tells the responsible gland to release the hormone. Okay? But these specifically are secreted by the hypothalamus. So it's not telling anybody, it's just doing it itself. Okay? So this is his job. We have growth hormone, thyrotropin, which initiates your thyroid, gonadotropin, which is your growth hormone, corticotropin, this is your steroid. Okay? And I had an accident at school. And then prolactin, which is for breast milk production. So these ones prevent something to happen. Okay? The hypothalamus is releasing these because it wants something to happen. Now, these guys are the inhibitor. So they're produced by the hypothalamus, but they're like, hey, I'm producing you because I don't want any more of this. So when I stop breastfeeding, I need to inhibit my prolactin. Okay? When I'm done growing, I need to inhibit my growth hormone. I can't just grow forever. I'd be really, really big and tall. Okay? Two others are the anti-thyroid hormone and oxytocin. So ADH we talked about is anti-diuresis. So think about giving drugs to diurese you, then that means you're putting out all of your fluid. If this guy is getting overproduced, I'm holding all of, oh, I'm cutting out. Okay. I'm holding all of my fluid. Let me connect to my hotspot. I think I did. Can you hear me? Please tell me I haven't been cutting out since 9:55 when Mike chatted it. Okay. All right. Yes, she said yes. Why didn't you tell me? You guys, if I don't, sometimes I can't see the chat thingy when I'm talking and I get, oh, yes, I can hear you. Okay, good. Okay. All right. So, and then oxytocin, we talked, this is our love hormone. This is, when we meet a boy or a girl and we're all feeling all that flooding feeling, it can make us blind to all of their red, horrible flags. This also makes us not want to eat our babies, okay? Because they're so cute and they're like, I just want to eat your little toes. But it makes us not do that. It makes us love them, okay? Oxytocin is also responsible for uterine contractions, okay? After we give birth. If you guys are going to go into OB, if you've had a baby, you know that they come in and they press on your uterus and they fudge it all around and you're like, what are you doing? Because it hurts. they're stimulating your uterus to contract so it goes back to its regular size. So oxytocin is a very, very important hormone.
I have a question.
Yeah.
I know we're gonna do it.
Yeah.
But like when you have a C-section, is that different? Like,
She said when she had a C-section, she doesn't really remember anybody doing that to you. So so they can. So what we don't want is what's called a boggy uterus. A boggy uterus is you feel in there and it's all squishy and it's not doing what it's supposed to be doing. Because a contracted uterus is going to be hard and you can feel it getting smaller and smaller.
Yeah.
So if your uterus is doing what it's supposed to be doing and contracting and getting smaller on its own, they're not going to be digging around in there. Now they're going to go in and they're going to feel around your stomach and they're going to find the fundus. The fundus is the top of the uterus. And every couple hours or so or whatever, they're going to see that, okay, the fundus has gotten lower and lower. If they don't feel that bogginess, that squishiness, they're not going to be digging around in there. Okay? Because if your uterus is not contracting, that's when you hemorrhage and you can have a postpartum hemorrhage and bleed out.
okay.
Okay, that's why oxytocin is so important.
Thank you.
And they give you oxytocin. So the Pitocin not only causes uterine contractions for the baby to come out, they also have it running after birth to help you contract and help your uterus go back to the way it's supposed to be.
And with C-sections, they scrape your uterus out. So a lot of that process is manually done because that's what your uterus does to get stuff out, but they do it for you to jump back in. So I'm sorry, that's graphic, but that's what they do.
That sounds terrible. Okay, enough of that. Enough of that. So hormones function within the body in two ways. One way is for to enter the cell and react with what? So if it's going inside the cell,
D.
C.
T. So the receptor sites inside the cytoplasm. So other hormones that are lipid soluble and non-polar actually enter the cell and react with the receptor site inside the cell. So the receptor site is either on the outside of the cell membrane, unlocking the door, or it needs to go into the cell to unlock the door. Okay, so there's receptor sites outside and inside. All right, let's take 10 minutes. I gotta pee. Be back in 10 minutes. Okay. Oh, sorry. Okay, ready? So, the pituitary gland is the next big guy in charge. He's like the vice president. So the hypothalamus is the president, and the pituitary is the vice president. So there is a very strong connection between the hypothalamus and the pituitary gland. The pituitary has an anterior and a posterior. And there is a capillary network that carries hormones from the hypothalamus directly into the anterior pituitary. Okay. There's also a neurological network that delivers the antidiuretic hormone and oxytocin to the posterior pituitary, which is where they are stored. Okay. It's important. They're stored in the posterior pituitary. They're not made there. They just hang out there. Okay. So hormones are released as needed by the body when it's stimulated by the hypothalamus with our negative feedback loop. Okay. You have 3 lobes to the pituitary. You have your anterior, your posterior, and your intermediate. We don't talk a ton about the intermediate, mostly just anterior and posterior. So your major anterior pituitary hormones include, I think I need to put my thingy back on. Hotspot. Okay. Can you hear me? Yeah. Okay. All right. So our major anterior pituitary hormones include growth hormone, our adrenocorticotropic hormone, which is a steroid, follicle stimulating hormone, luteinizing hormone, prolactin. And then we also have our TSH, which is the thyroid stimulating hormone. So all of these are essential for growth, reproduction because of our FSH and LH specifically, and metabolic processes like our growth hormone and our ACTH and our thyroid. Okay, we need all of these things so that we can work correctly. Our metabolism can work correctly. And they're released in a rhythmic manner. So they're released in a very standardized manner, but at the same time, if we need more, then it releases more. Okay. So the intermediate lobe produces endorphins, and enkephalins, don't need you to know that word. Endorphins is like when you exercise and all of a sudden you feel really good afterwards. Those are endorphins. Okay. This enkephalin, no, I don't like that word. And endorphins is a good word to know though. And it's released in response to severe pain or stress, also produced in peripheral tissues and other areas of the brain, and it secretes the melanocyte stimulating. Okay. Endorphins can be good or bad. So endocrine regulation, these hormones are released in small amounts to accomplish what needs to be done to maintain homeostasis. If they get triggered within the negative feedback system, then they get triggered to be released. Fine tuning is regulated by that negative feedback. And then other hormones are released in response to direct stimulation, either internal or external. Okay. I told you the hypothalamus and the pituitary act very closely together. Function using the negative feedback systems to maintain everything, to maintain homeostasis. So if you didn't already realize what the negative feedback system is, it's all about supply and demand. If my body is demanding, I have to increase my supply. If my demand is less, then my supply decreases.
I feel like we can't hear you.
Breaking up. Maybe I shouldn't be on my this is a rough one from Can you hear me? Okay. Did you hear about the supply and demand? Or
That was breaking up.
Okay, so your negative feedback system works on a supply and demand. Okay, so if my body is demanding more, then I have to increase my supply. If my body is demanding less, then my supply can be less. Okay, so the hypothalamus is going to sense a need for a particular hormone. The negative feedback system literally works the same way every time. You just have to think about the pathway. Okay. So something in your body says, I need more, right? When we were talking about the RAS system, it was because we didn't have enough blood flow. So we needed to increase the blood flow by increasing the blood pressure. With our endocrine system, we're seeing a lack of a hormone. So if I don't have enough T3 and T4 from my thyroid, then my hypothalamus is going to say, hey, I'm going to secrete TSH, which is my thyroid stimulating hormone, and it's going to tell my thyroid that I need more T3 and T4 to circulate through my body so that I can have a normal functioning thyroid. So it all is a cycle, constant cycle, just depending on what it is and where it gets released from. So the hypothalamus is going to sense that need. It secretes the releasing hormone or factor that is directly from the anterior pituitary. So the anterior pituitary either has the hormone or it's going to tell the body to do another thing. Okay? So this stimulates the gland to produce a hormone. The hypothalamus will sense that what it was told is rising, that demand, we're meeting that demand, so then we're going to stop secreting the hormone. Okay? It's thought to be more complex. It's really very simple. If the demand is there, the supply has to be increased. It just all depends on where the supply is coming from and who is sensing the demand. Okay? I guess I just talked about this, but for the thyroid, your hypothalamus is going to sense that the TSH is low. Okay. So then it's going to send a signal, release a hormone of TRH to the anterior pituitary. The anterior pituitary says, okay, I'm going to put out TSH. That TSH is going to go to the thyroid gland, and then the thyroid gland is going to make thyroid hormones. Okay. So when we think about the negative feedback system, how many stops do we have to make? Are we making one stop where the hypothalamus is just going to secrete a hormone and that's going to be the supply? Or do we need to start here and stop at the anterior pituitary and then stop at the thyroid gland and then we get to where we need to go? How many stops do we need? It all depends on what the hormone is. We didn't talk about this yet, but if you had to guess, aldosterone is part of the RAS system, has nothing to do with fight or flight, right? Anti-diabetic or diuretic hormone stops diuresis. So I will say that when you're in fight or flight, you're not making a lot of urine. I will tell you that. ADHD, I have that. That's not a hormone. I have it though. ACTH, that's our adrenocorticotropic steroid. What increases when we're stressed? Cortisol, our steroids. So by process of elimination, we have a 50-50 shot between ACTH and ADH. Okay? We just worked right through that problem without even knowing what it could be. So we have two solid choices. So activation of the sympathetic nervous system directly causes the release of ACTH and the adrenocorticoid hormones to prepare the body for an acute stress response. When your body is stressed, you will be flooded with steroids. I'm not talking about when we put steroids in our body like IV or PO, these are mimicking our body's natural steroid. Okay? We have glucocorticoids, which are like a glucose steroid. We have adrenocorticoids, which come from the adrenal gland. Cortisol. So it does say that aldosterone is secreted in response to ACTH, but it's not directly in response for the sympathetic nervous system. It's only for potassium. So the question was specifically asking about fight or flight. Okay, any questions about that chapter?
Not necessarily a question, but I think I understand steroids. Yes, it's probably.
We're going to go over steroids more.
I think something about steroids. I think about weight gain.
Yeah, weight gain. Yeah, totally. But also hyperglycemia. But what if you don't have any steroid? What if you don't have any steroid protection and you can't adequately respond to a stress response? That's when you have a big problem. Big, big, big problem. Tony, I saw your message. That's fine. Jamal, do you want to try to, if it's your laptop, do you think you need to maybe come on through your phone and then like shut down your laptop and try to reboot it? I think that might help. I don't know if you can hear me. Okay. All right, let's go into chapter 35. So, I mean, we already. Yes.
I'm sorry. I was trying to type it out because I kept cutting in and out. But I've never done lecture on my phone, but I can try.
Yeah, just go through the link on your phone And then try to shut down and restart your computer and see if it helps.
Okay.
Okay.
All right.
I'll watch for you to pop in on my thing to let you in.
Okay.
So we already covered this, but the main function is to maintain homeostasis. Too much or too little of the gland activity is going to disrupt our normal homeostasis, lead to disorders that are not fun to deal with, and then interferes with the normal functioning of the endocrine glands. We already saw this picture. We already went over these in the last chapter. So we have stimulating hormones, we have inhibiting hormones, and then we also have the ADH and oxytocin that are made there. So these are drugs that affect the hypothalamus. So Lupron, this is a common fertility medication. It kind of suppresses the entire fertility response, so they can kind of shut it down and then restart it with IVF. I would say they all have an ending of relin, R-E-L-I-N, except for the leuprolide. And the side effects suck. Yes, they do. Yes, ma'am, they do. They sure do. The antagonists, they end in relix, R-E-L-I-X. So this is either going to help or work against the hormone production. So which one is going to help? Agonists. And then the antagonist, if you think about it kind of like an on-off switch, these are going to turn on more receptors, and these are going to turn off. The antagonists are going to turn off some receptors or inhibit them. So this is just saying that not all of our hypothalamic hormones are used as drugs. Only the ones that we absolutely have to synthesize are used as drugs. And it all depends on what the disease is and what the indication is. And that it is extremely based on how it's made, how it's given, and what exactly it's for. So most of them are excreted in the urine, means that we definitely need to make sure we have adequate renal function. It crosses the placenta and enters human milk. So either A, it's contraindicated in pregnancy, or we need to be very cautious. Okay. So contraindications, pregnancy and lactation. We are not giving these hormones to pregnant people and lactating humans. We also need to be really careful with patients that have cardiovascular disorders. These can be given as a nasal spray, some of them. And it's very common to have an itchy nose and sneezing after they're administered, especially if they're needed for kids. It's a lot easier to do like a little mist up their nose than it is to be stabbing them with needles every day, right? Because if they need growth hormone or if they need, whatever hormone, you want it to be as easy of an administration as possible. So the adverse effects are going to be related to the stimulation or blocking of the regular hormone. So if I'm blocking prolactin, I'm going to have an adverse effect or an expected effect of no more breast milk production, right? If I'm giving oxytocin, I'm expecting to see uterine contractions. Okay. So am I stimulating by giving this drug or am I blocking by giving this drug? Agonists may trigger initial disease flare-ups due to the transient increase in hormone levels. This just means when you first start the treatment, it could make you feel worse before it gets better. And then anything that you inject in your body, an injection site reaction is going to be across the board one of your expected adverse effects, right? Redness around the site of injection. Now, if it's really bad, where it's, anaphylactic or there's hives all over your body, that's obviously not normal or expected. But an injection site reaction, a little redness is normal. So this is taking a closer look at leuprolide, which is Lupron. So this causes a initial increase and then a very, very big decrease in luteinizing hormone and follicle stimulating hormone, which is why it's used in reproduction medicine. Yeah, it causes an initial increase, which is where you see that flare, and then a profound decrease in the luteinizing hormone and follicle stimulating hormone, which is why they use it in reproductive medicine. And it can be used for the treatment of prostate cancer, endometriosis, central precocious puberty, which means early onset puberty, uterine leiomyomata. Ooh, that sounds terrible. Pretty sure that's a uterine, like fibroid tumors. So you can see dizziness, headache, pain, peripheral edema, a myocardial infarction. I mean, these side effects are very serious with these drugs. Anorexia, constipation, urinary frequency, hematuria. Testicular atrophy. Hyperglycemia. I think I'm gonna go get my book. So I want to point out some things to you guys. I'm gonna go grab my book really quick. All right. I'm whipping out my Karch's book. So, you guys have all of your books through Lippincott that you can look at page numbers and things. So, in chapter 35 on page 592, so it shows all of the drugs that were listed on the previous slide. 592. So you have one drug, the nephrelin, which is the nasal. This is for the treatment of endometriosis and precocious puberty, which is why it's given to children to try to put off early onset puberty. And it is given one spray in the left nostril, AM or PM, and then one spray in the right nostril, AM or PM. And then precocious puberty, it says it is just gives a microgram for intranasally. Okay. Most of these other ones are all sub-Q. Actually, all of the other ones are subcutaneous. Oh, one's implanted. Okay. Naphrelin. That's the intranasal. Yeah, it's in table 35.1. Okay. So on the next page, 594, is where we're going to go into the drugs affecting the anterior pituitary. So the uses for these drugs are either replacement therapy or for diagnosis. So growth hormone agonist, your most common is going to be the somatotropin. And then the growth hormone antagonist, your most common are going to be the bromocriptine and octreotide. Okay. So somatotropin is given to treat for treatment of children with growth failure, and it's a lack of growth hormone. So it's going to help them grow, stimulating the growth hormone. Okay. And then the bromocriptine, this is for treatment of acromegaly, which is the overgrowth, which is where we have kids that don't stop growing, where all of a sudden you have someone that's like 8 feet tall and it's like gigantism, which is also called acromegaly.
Miss Simmons,
Yeah.
I'm sorry. And somatropin, I was thinking Samoans are a large people, so tropin help the growth hormone. Do I have it backwards?
So somatropin is going to help them grow. We want them to be
Big
like Samoans, but they're
Okay.
not. They're small. They're teeny people, and we want them to
Okay.
be bigger people.
Thank you.
You're welcome. That was good. That was a good one. Hopefully no one is Samoan and took offense to this.
I mean, no offense. The bigger the
Oh.
better in my world.
No,
I agree. Yeah, I mean they're big dudes. So, anyways, bromocriptine is for the treatment of acromegaly. This is all in table 35.2 in your book on page 594. And this helps stop the growth. Okay, so they're antagonists. We want to inhibit. And then the octreotide, this can be a treatment for acromegaly also. And those are going to be your most common on this list. So whenever you see gonadotropin, gonads, this is most likely going to be affecting your sex hormones. Okay. Thyroid. Cosentropin, like cortisol, this is going to be your steroid. Okay. I'm pretty sure this is the drug to inject my sequence to make myself late when I was ready for like intrauterine insemination. It's Ovidrel. So our agonists, these are going to stimulate overall growth and production. Okay. And it is for the treatment of growth hormone deficiency. So this is dwarfism. It says GH deficiency in children results in short stature, which is dwarfism. Adults with somatropin deficiency may have hypopituitarism and can be a result of tumors or trauma. So if you want to initiate growth in a child, what do you think they're going to feel? Pain. I can't hear you. Tired? I mean, maybe
Jess, you're cutting out.
I don't know how to fix this. I'm like going back and forth with.
Every time I kicked up your growth spurt, it was knee pain. Every time.
You said
Knee pain. That's how I knew my son was going through a growth spurt. He complained his knees hurt all the time. Not 6'2" and still not young girl.
Okay, can you hear me? Can you hear me now? Okay. Okay. I'm connected to my hotspot. Okay, so I was saying that when you see a growth hormone deficiency, this is on page 595, in children, it results in dwarfism. And adults with somatropin deficiency have hypopituitarism. And this can be caused by pituitary tumors or trauma. And I was saying that if you have a child that is taking growth hormone, then the adverse effect that you would expect would be pain. Okay, I literally remember waking up in the middle of the night crying, literally crying from growing pains. And my mom would rub icy hot on my legs. And then I remember wrapping my legs in blankets because they were so cold, but it didn't hurt anymore. But I remember it really, really hurting. And then There was a time where they actually said that growth pains weren't real. Girl, I remember it. So if you're initiating growth in a child, you're going to expect myalgias, muscle pain, skeletal pain, arthralgia, which is joint pain. Why would they give pain probably not, Tony. She said, would they give pain meds with GH meds? Probably not. And I don't think it would be like an extremely painful thing. And when you're on growth hormone, you're on it for like an extended period of time. Like these are for somatropin, doses vary based on indication and product, must be given subcutaneously or IM daily. So this is every day. I mean, could you give your kid some Tylenol every day? Sure. Yeah. But you're not going to give them like Oxy, you know? But yeah, I remember, and it sucked. So somatropin is injected. It reaches its peak level in 7 hours. And it says in the book that it's given every single day. It's widely distributed in the body and it's excreted through the urine and feces. So that means we need to have adequately working kidneys. Okay. This is another really important thing right here. Epiphyses. What does that mean? Epiphyseal plate. What is that? That's your growth plate. Growth plate. Okay. So at the end of every one of your long bones is called an epiphyseal plate. Okay. And it's open while we're growing. Once your epiphyseal plate closes, you are no longer able to use growth hormone.
Hold on. So epiphysis is the end of the what you say?
At the end of every long bone, you have an epiphyseal plate, which epiphyses is the like plural.
Oh. Okay.
Okay.
Yeah.
Same thing, just plural. So if your epiphyses or your epiphyseal plates are closed, so puberty for most people when the growth plates close. For most people, yeah, I mean, you have to be very careful. And the way that they can tell if the plate is closed is by x-ray. Okay? So on page 595 under contraindications and cautions, it says it is also contraindicated in the presence of closed epiphyses when indication for use is linear growth. So long, tall, linear growth. And if active malignancy is present, Jesus, due to potential for enhanced tumor growth. So if the long bones can't grow anymore, you can't continue giving the growth hormone. Also, it says caution should be taken with patients who have underlying cranial lesions because of the risk of increased intracranial pressure. With patients that have glucose intolerance, it can worsen their glycemic control. So type 1 and type 2 diabetics. So contraindicated when the epiphyses close and very cautious for underlying cranial lesions that can get worse and bigger. Your skull is only so big. Okay? And when those sutures, those openings in your skull when you're born, when those close, we call those suture lines, there is no more space. Okay? And you can only fit so much in there. So if there is increased intracranial pressure, especially if there's too much, that can lead to brain death. Okay, it's like suffocating the brain. So we don't want to increase any intracranial pressure. It's very bad. Acute critical illnesses, because it can make it worse. And like I said, glucose intolerance. So adverse effects, especially because most of these are subcutaneous injections or IM, you could have injection site reactions. Peripheral edema, myalgia, which is your muscle pain, arthralgia, which is your joint pain. Development of antibodies, which in that case, they just wouldn't work anymore because your body's going to attack it. Hypoadrenalism, that means that it's affecting your adrenal glands and your adrenal glands are no longer working properly. Hypothyroidism, you don't have enough thyroid hormone. Pancreatitis, this is inflammation of the pancreas and could possibly lead to affecting your insulin production. So when you treat people for these diseases, it's very important that you're watching them closely for all the things that it can cause. These are not drugs that you just willy-nilly throw at people and you're like, here you go, because they could really do some damage. Drug-to-drug interactions, glucocorticoids, if your patient already is being caused to have a glucose intolerance, and then you add on glucocorticoids, which is going to increase their blood sugar even more, you're talking about pretty hefty hyperglycemia. Okay? And it says caution should be used when these agents are combined with any drugs using cytochrome P450 because of a risk for change in metabolism of the combined drug. I don't need you to know that, but it's on there. In your book, I really like these things right here. Where you can see they're like a different color on the page, and they're called nursing considerations. And I like how it combines a lot of stuff. So it starts with your assessment, your nursing conclusions, planning, intervention, and then evaluation. It goes through the entire nursing process for every category of drug. I really like those. So pay attention to them. Okay. So in this little box, it talks about the assessment and history, about the epiphyses, the acute illness, whether the patient is glucose intolerant, pregnancy and lactation. It also tells you that you should assess the patient's height, weight, thyroid, blood sugar, and their growth hormone before you even start. It tells you that there's altered nutrition because it changes the metabolic process. There's acute pain. There's going to be a knowledge deficit for everything because we talk about how our education, especially patient education in this country, is trash. Planning, how can this help our patient the most? And how can we help them and educate them the most for them to be successful? Intervention, we want to make sure we're monitoring throughout the entire therapy and making sure that they're okay. Their kidneys are okay. Their adrenal glands are okay. Their thyroid's okay. They're being properly nourished. These are children we're talking about most of the time. Okay. Storage of the drug, refrigeration is required, it says. Preparation of the drug, if it has to be reconstituted. You need to teach how to administer because they're going to be getting this at home. They're not coming to the office every day to get a sub-Q injection. You're giving this to your kid at home. And then evaluation, monitor the patient response. How are they growing and their development? Adverse effects, how's their thyroid? How's their blood sugar? Their nutrition, are they getting enough nutrition? Evaluate the effectiveness of the drug. And then comfort measures and compliance. So if you were giving me this drug to give to my kid, what do I need to know? What would you tell me that I should expect? Pain. You damn sure better tell me that my kid's gonna be in pain. If you don't tell me and my kid wakes up in the middle of the night screaming because his legs hurt so bad, and you're, oh, I should have told you, sorry. Excuse me. You could have told me that. Okay? So this is just asking pretty much, is this drug an equivalent to our natural hormone of the growth hormone? Is it equivalent? And it is true. So somatotropin is a synthetic growth hormone, meaning that it mimics our natural growth. Okay, so whenever you see the word synthetic, it means that it is very, very close, if not identical, to the natural hormone. Okay. We're going to go to lecture 12. So these, now we're switching from agonist to antagonist. Okay. So this is going to be for the treatment of acromegaly. So very, very big and tall. These are your, what did she say?
The Samoans.
The Samoans? These are your Samoans. These are your, and I'm being very serious. So this is your patient that has gigantism. They are literally like 8 feet tall.
You're 6'4".
Their hands are as big as like my torso. Okay. And overgrowth like that, it doesn't just affect your skeletal and muscle. It affects every organ in your body. Your heart, your lungs, your intestines, your kidneys, everything. Okay? Obviously, a contraindication is an allergy. So this is looking at the bromocriptine. I told you was one of the most common. So on page 597, it says that bromocriptine is a semi-synthetic, and it's a dopamine agonist that can be used to treat acromegaly and hyperprolactinemia, so a lot of prolactin. It may inhibit growth hormone by increasing the dopamine that facilitates more somatostatin release from the hypothalamus. So it's going to inhibit the growth hormone. Bromocriptine is administered orally and effectively absorbed from the GI tract. It says that it should be used during pregnancy with extreme caution due to increased risk of inducing hypertension. It also should not be used during lactation because it will stop lactation, because it will inhibit the prolactin, and it can affect the fetus. Any questions on any of the drugs that we covered for the hypothalamus and the anterior pituitary? I want you to definitely look at your book. Okay. Especially when I give you page numbers.
Is this the ATI book or is it the
No, ma'am. This is Karch Pharmacology, 9th edition.
Got it? Thank you.
Mm-hmm. I think octreotide, I feel like somebody told me it was on ATI. Octreotide. Octreotide is on page 597. It says that it's been associated with the development of acute cholecystitis, which is an inflamed gallbladder. So it can cause jaundice, biliary obstruction, and pancreatitis. So you want to monitor those patients for acute cholecystitis. Okay. And also dysfunction because they could accumulate a lot of the drug. This is on page 597. And I'm pretty sure octreotide is a drug that they ask questions on in your ATI. So they have another one of these nursing considerations for the hormone antagonist. Make sure you look at it. For both the growth hormone antagonist and agonist, it tells you that you have to monitor thyroid function, glucose, and the growth hormone itself periodically. Thyroid, glucose, and the growth hormone levels. Arrange for baseline and periodic ultrasound evaluation of the gallbladder if using octreotide. Okay. So moving on to the posterior pituitary. The most important drugs on this list is desmopressin and vasopressin. Desmopressin, you're going to hear me refer to as DDAVP. They're interchangeable. But I need you to definitely be able to recognize both terms, desmopressin and DDAVP. Vasopressin is a very special drug that we can use as a pressor in critical care to increase blood pressure when our patient is dying and in shock. It is one of our pressors.
So when you hear pressors, that's what it's for.
When you hear the word pressor, that means that your patient is needing help to keep their organs perfused and increase their MAP, their mean arterial pressure, greater than 65. Because if it's less, then their organs are not being perfused. So you have 4 vasopressors, you have 4 vasopressors, which are not part of this lesson, but we'll talk about it in complex care. See, I'm allowed to say that because I teach complex care, okay? At least I'm giving you a snippet, all right? So Therapeutic actions and indications. So when we have either too much ADH or too little ADH, which is your antidiuretic hormone. So these drugs are going to produce ADH activity in the kidneys, increase water reabsorption, and decrease urine formation. Have you ever heard of diabetes insipidus? It does not have anything to do with diabetes mellitus. They are two very, very, very different things. Diabetes mellitus has to do with the pancreas and your blood sugar. Diabetes insipidus all has to do with ADH, your antidiuretic hormone. Okay. Diabetes insipidus is the massive, massive, massive loss of fluid. I'm talking 7 to 20 liters of urine output a day. Massive fluid loss. So if I'm losing an insane amount of fluid, what do I need to do? Replace it? If I replace it, I'm just going to keep losing it. No. I mean, yes, but no. What's the very first thing I need to do?
Which is it?
Stop the loss. She said, plug it. Plug it. I mean, in a way, I guess. You're going to give desmopressin, DDAVP, or vasopressin. And it's going to inhibit, well, actually, it's going to cause ADH to be released, to stop the urine from being released, which will retain the fluid. Then you give fluid. Now, I'm not talking like you give DDAVP and then like 3 hours later you give IV replacement. I'm talking about you have the desmopressin in your hand and you have a liter bolus already waiting. You give the DDAVP and then you start your fluid replacement, right? But there's no point in massively replacing fluids if you don't correct the underlying issue. Okay? So desmopressin on page 599, it says, is a synthetic analog of the natural posterior pituitary hormone ADH and is indicated to treat diabetes insipidus. Vasopressin is also synthetic ADH, but it is indicated for increasing blood pressure in adults with vasodilatory shock or in clients who remain hypotensive despite fluids. And that's your critical care. Okay.
Hey, Miss Simmons.
Yeah.
Is vasopressin similar to midodrine?
Midodrine is like a cat, and vasopressin is like a tiger. Do they do the same thing? Do they do the same thing in a way? Yes, but on way different levels. Good question. Because as if you're an LPN, especially in long-term care, if you work with patients that have spinal cord injuries, you give midodrine about 27 million times a day. So similar, but very different playing fields.
My patient get
4 times a day.
He stressed me out. He get hydrolysine, amlodipine, carvedilol, midodrine 3 times a day. But of course, you don't get none of the other stuff. If his blood pressure, it just, I don't understand it.
It's because he has other cardiovascular diseases. And I bet you he has AFib. A history of AFib.
I bet you it's a heart rate control. I bet you the meds are heart rate control and the midodrines keep the pressure up.
So you said that he's on carvedilol?
Yeah.
So beta blocker, amiodarone, right? Which is an antiarrhythmic. And what was the other one?
Is carvedilol, hydralazine, amlodipine.
So amlodipine is a calcium channel blocker. Carvedilol is a beta blocker. And then hydralazine is your antihypertensive. So I guarantee there's a conduction problem with a history of AFib. There's some type of arrhythmia that is occurring. Okay, so I need you to know backwards and forwards what diabetes insipidus is, how we treat it, and why.
Why we use that med to treat it?
Yeah.
Okay.
Contraindication for this drug, severe renal dysfunction. Now, granted, I would probably be surprised if a patient is experiencing DI with severe renal dysfunction. It'd probably be hard to see because if you have severe renal dysfunction, you're not urinating a lot. So it'd be interesting to catch it, actually. You want to be cautious with known vascular diseases, asthma, and hyponatremia. So on page 600, it says drugs affecting the anterior pituitary hormones are contraindicated with any known allergy. Blah, blah, blah. We knew that. Severe renal dysfunction, which could alter the effects of the drug. Caution should be used with any known vascular disease because of its effects on vascular smooth muscle. Asthma and hyponatremia, which could be exacerbated by the effects of the drug. Desmopressin is another drug that can be given intranasal. It can be given sub-Q and intranasal. Oh, and oral and IV. IV, oral, sub-Q, and intranasal for desmopressin. On 601, the adverse effects associated with the use of desmopressin and vasopressin include water intoxication. And this is related to the shift of water retention, which results in the electrolyte imbalance. So your body is dumping fluid. You are extremely dehydrated. So everything is extremely concentrated. And then all of a sudden, you stop that dumping from happening. And you cause the body to retain huge amounts of water. You're going to see a massive electrolyte shift. This is very dangerous. When this happens, especially with sodium, if your patient is already hyponatremic, your patient already has low sodium, less than 135, and then all of a sudden they start retaining a massive amount of fluid, you're going to see a very, very big shift causing even more hyponatremia. Hyponatremia leads to confusion, CNS disturbances, your central nervous system disturbance, seizures, and coma. Hyponatremia is very serious. So if your patient is already hyponatremic, you need to be very cautious because you're going to induce even more severe hyponatremia. Does that make sense? Okay. Drug-to-drug interactions. You want to be careful with desmopressin and carbamazepine or tricyclic antidepressants, TCA, tricyclic antidepressants. Alcohol. You want to make sure you're checking potential interactions. This is usually the drug of the pharmacist, or the job of the pharmacist. But as nurses, it is our job to be our patients' eyes and ears and advocates. So if it's not flagged by the pharmacist, it needs to be flagged by you. So this is just taking a closer look at desmopressin. It can be used for neurogenic diabetes insipidus, von Willebrand disease, which we didn't really talk about, or hemophilia. It can be used for treatment of nocturia in adults. It is used for the hemophilia and von Willebrand syndrome because it increases the clotting factor 8. So when we look at adverse effects, we see headache, dry mouth, facial flushing, fluid retention, an increase in blood pressure because you're holding on to volume, water intoxication in high doses. You can die from water intoxication. That's why you can't give babies water before 6 months. That's why it's so important to follow the instructions on the can of formula for your babies. And you don't dilute it more because they're not capable of, their kidneys are not capable of the fluid balance. And they can die of water intoxication. Okay. There was a radio show, I think it was like 10 years ago or something. It was in the 2000s. I just don't remember when it was. But this lady, healthy woman, the competition was how much water you could drink and how fast you could drink it. And she died of water intoxication. I think she drank like a gallon, maybe 2 gallons in like 20 minutes or something crazy. Yeah, it was really bad. It was a huge, huge story. Because people didn't really understand how water intoxication happens and that it was even possible. And it was a huge deal. Huge, huge deal. So a nurse is caring for a 10-year-old patient with growth hormone deficiency. The child asks the nurse, how long will they need to take this medicine? What is the best response?
Let's see, I like that. Just however long you want.
Until you decide to stop.
When you're done.
Yes, until your epiphyseal plates close. Okay. Remember, they have to have periodic testing for their thyroid, blood glucose, glucose intolerance, and for antibodies. And they need to have x-rays to take a look at the long bones to make sure that the epiphyses are still open. Okay. Okay.
Can you let me in on my phone, please?
Yeah. Well, we are going to lunch. So let's take a half-hour lunch. Let's come back at 12:30.
Let her eat her food, please, okay? You just had lasagna.
Tony wants to know if anybody has a list thus far of page numbers that I have mentioned. I will say I brought the book out in chapter 35.
I think it started at 592 and go from there. I think 592 was the first page that was mentioned.
Yeah, I think you're right. We got to get through 36 and 38 because 38 or 36 and 37 because 38 is long. 38 is all diabetes. Diabetes. The Wilford Brimley diabetes. God, I love that, guys.
Hey, Jess.
Yeah.
Quick question.
Yeah.
Because I know we had a problem with it before. When we get to diabetes and everything with insulin, to the ATI,
Gosh,
Simple Nursing,
I
the
forgot about
main book. I remember before we decided the ATI because it was the closest to when we take our ATI proctor.
Yes.
Is that still what we're gonna do?
I mean, I feel like that's the right choice because I don't want it to affect you when you take
Okay.
your ATI lecture.
Okay.
I don't want to teach two different things.
Yeah.
But I will say they are close. They're not exact though. So my nose hurts. I gotta find my H. I gotta get my ATI. Do you have your ATI book, Chastity?
Yeah.
All right. Can you look up, can you find the page for when we get there?
Yeah.
Okay. All right.
Side note, quick question. Do you get runny nose syndrome from your surgery?
No, I sneeze.
My nose runs for no reason whatsoever.
I just have, my nose is so dry from the weather, and I think it's just ruining.
They say, oh, if you're hungry or full. No, mine's because it's a Tuesday at 12 o'clock. My right nostril just pours for no reason. Or vice versa.
No, if I even take one extra bite, I will sneeze my face off. My husband, he hiccups.
Mm-hmm. Me and my husband both get the runny nose.
All right. Let's get to it. We need to finish chapter 36. We need to get through 37 because 38 is long. So, chapter 36 is adrenocortical agents. So, cortical, we're talking about steroids. Okay. Think like corticosteroid. I want you to make that link in your noggin. Okay. So these are widely used to suppress inflammation and the immune system. Okay. When your patients are having a suppressed immune system, what are they more at risk for? Infection, whether it's bacterial or viral. Okay. So your patients are more susceptible of getting sick. What is the number one thing that we can do that can decrease their risk of getting sick? And wash your hands. Okay? These drugs do not cure inflammatory diseases. Inflammatory diseases suck, and they are, from what I know, they're not curable. I don't know if any of them are curable. They're just put into a maintainable place with these drugs. Okay? These may be used as replacement therapy for people with adrenal insufficiency. This is going to be important when we talk about adrenal insufficiency. This is also important. Not used as long-term therapy if there is a safer alternative. You should never be on steroids for life unless the benefit outweighs the risk. But most of the time, the risk is way too high to be of any benefit. Also, when you take steroids, do you abruptly stop them?
No.
No. You do what? You taper it down. Yes, you taper it down. So, we know that the adrenal glands sit on top of the kidneys. Okay, you have the adrenal medulla, and then you have the adrenal cortex. The adrenal cortex is like the outside. The medulla is the inside. So it's like, kind of like a fruit. Okay, so like the cortex is like the skin of the orange, and the medulla is like the yummy stuff in the orange. Okay. And the adrenal cortex, the outside of the orange, is what produces the corticosteroids. It controls our diurnal rhythm. Your diurnal rhythm, actually, just so I don't screw it up. The adrenal cortex, this is on page 607. We just started chapter 36. The adrenal cortex responds to adrenocorticotropic hormone, which is ACTH, released from the anterior pituitary. ACTH in turn responds to corticotropin releasing hormone released from the hypothalamus. This happens regularly during a normal day in what is called the diurnal rhythm. A person who has a regular cycle of sleep and wakefulness will produce high levels of CRH during sleep, usually around midnight. A resulting peak response of increased ACTH and adrenocortical hormones occurs sometime early in the morning around 6 to 9 a.m. So this is saying that when we go to sleep at night, it's normal for us to sleep at night. It's not normal to stay up all night and work and then sleep during the day, right? For some people, it becomes a normal. We were just talking about that with me and some of my students here in North Canton. We're talking about working night shift and then coming here and going to class and then going home, not sleeping, and then having to work again tonight, which is super dangerous, by the way. Also, this is just a PSA. Do not ever post on any type of social media that is what you are ever doing. Because if something happens and you make a med error, or if something happens to a patient, they will use that against you in court. Just a PSA. You shouldn't be doing it in the first place. Miss ma'am. Gotta do what you gotta do. I know, we gotta do what we gotta do. But I'm just saying, when it just popped into my brain, when it comes to social media, be very, very careful what you post on Facebook. Because not only can you use your nursing license, you're gonna lose your job. And it's a big, big, fat, ugly thing. Anyways, back to this. So, your diurnal rhythm is kind of like your circadian rhythm, but talking about the hormones. So it's normal for hormones to be released around midnight. It's normal for another set of hormones to be released in the morning, and this is going to help your sleep-wake cycles. Okay? When this gets all messed up, we have a stress response. Okay? So, the hormone actions. We have increasing blood volume from aldosterone because aldosterone causes us to retain salt and water, right? It causes the release of glucose for energy. Where does glucose live when we're not actively using it? The liver. In the form of what? Glycogen. Okay? Glucose, our extra glucose, lives in our liver in the form of glycogen. When we need it in response to a low blood sugar or in response to fight or flight, which is a stress response, your liver says, hey, I have this glycogen, so we can make more energy in the form of ATP from our mitochondria. Okay? And it gets released from the liver in the process called glycolysis. Okay? You're going to hear me talk about this multiple times in this month and the next months that you have me. Okay? So, causing the release of glucose for energy. That's why, especially women, when we have a high cortisol, that means we also have a very high sugar. We can't lose weight because we're constantly in need of sugar and energy because we're constantly stressed. Okay? This is why cortisol hates us. Okay? So, it also is slowing the rate of protein production in most cells and increasing protein breakdown. It's bad. Bad. Okay? I need protein. Every one of my cells, all of my ATP, all of my cells are lined in amino acids. Amino acids are proteins. I need proteins to survive. Okay? So if I'm slowing the rate of protein production, that's not good for me. I need my protein. Okay? In most cells, an increasing protein breakdown. Protein, guess who doesn't like protein molecules? The kidneys. They don't like them. Your glomerulus and your little nephrons and all the little tubules, they don't like big molecules. Proteins are large molecules, okay? And are you supposed to find protein in urine? No. No. Where do you think this breakdown of protein is going to go? In your urine. In through your glomerulus, your nephrons, in through the tubules. And guess what that does? Trauma, AKI, acute kidney injury. Okay, this is not good. Mobilizing fatty acids into plasma. Cholesterol, bad. Okay, decreasing the activities of the inflammatory and the immune system, which preserves energy because we're in stress. We need energy. So if I'm decreasing, guess what? I'm also getting sick. I'm stressed, I'm fat, I'm sick. Sound familiar? Nursing school, ding, ding, ding. Okay? All from your corticosteroids. Okay? So there are two big diseases when it comes to adrenal glands. And you better know these back, front, and forwards. Diagonal, all of it, every which way. It starts on page 608. So when you have too much, the adrenal excess, this is called Cushing's syndrome. Okay? This can result from adrenal hyperplasia. So hyperplasia meaning my cells are big. They're too big. They're not supposed to be that way. Okay? Or a tumor on the adrenal glands. Or a adrenocorticoid hormone releasing tumor. That can happen. You can have tumors do crazy things. Tumors can release all kinds of things. Okay? Or an early sign of excessive administration of exogenous steroids. What does that mean? That's a big, fancy word. Exogenous steroids.
Man-made.
That means that I just pumped you full of prednisone, methylprednisolone, dexamethasone. I just pumped you full of it, and it's too much. Okay? You can absolutely overload a person with steroids, and it will crash their adrenal system. Okay? So, Cushing's is caused by too much ACTH. Then we have adrenal insufficiency. This occurs if a person does not produce enough ACTH. Your adrenal glands are not responding. The gland could be damaged. It could be surgically removed. Or you could kill it by using too many steroids. Okay? And this is what we call Addison's disease. They are opposites of each other.
So too much ACTH or too little ACTH?
So Cushing's is too much. Addison's is not enough. Okay? Then we have what's called adrenal crisis, which is on page 609. It says patients who have an adrenal insufficiency may... Am I cutting out? Nobody said anything, and I just want to make sure because I disconnected from my hotspot. We're good?
No, we can hear you.
Okay, make sure you say something when it stops because you know it's going to stop. All right. Patients who have an adrenal insufficiency may do quite well until they experience a period of extreme stress, such as a motor vehicle accident, a surgical procedure, or a massive infection. So something that is causing a huge stressor on your body. Because they are not able to supplement the energy consuming effects of the sympathetic reaction, which is fight or flight, they enter an adrenal crisis, which can include physiological exhaustion, hypotension, fluid shift, shock, and even death. Patients in adrenal crisis are treated with a massive infusion of replacement steroids, constant monitoring, and life support procedures. This is very dangerous. So if you have a patient that you know has adrenal insufficiency, you know they have Addison's disease, okay? And they are getting ready to go into a surgical procedure. What do you think they're going to do? Give them a bunch of steroids because they know that you're already insufficient and they know that you're going to crash if they don't give it to you. Okay? Very important concept to understand. On the bottom of page 608, table 36.1, signs and symptoms of adrenal dysfunction. On the left side, you have Addison's. On the right side, you have Cushing's. Okay. Didn't I add something on Brightsmith? Yeah. Okay, so this is on Brightspace in week 2. Okay, so Cushing's, disorder of the adrenal cortex, there's too many steroids. They have a Cushing. Okay, our patients are usually female. There's an overuse of cortisol medications, or it's a tumor. Okay, your signs and symptoms of Cushing's include muscle wasting, moon face. You ever see someone that takes a lot of steroids and their face is very round? Okay, that's what we call moon face. A buffalo hump. Right here, where you got that big hump on your back. That's a buffalo hump. Truncal obesity with thin extremities. So you got big old trunk, but we got little teeny tiny legs and arms. Okay? Supraclavicular fat pads. This is my clavicle up here. Supra meaning on top. So big fat pads here. Okay? Weight gain, hirsutism, facial hair. Okay, and it says masculine characteristics. Increased glucose, because when we have increased steroids, we automatically have hyperglycemia. Hypernatremia. This is going to be a big difference between Cushing's and Addison's. Cushing's, way too much salt. Addison's, no salt. Not enough salt. Okay? Decreased potassium, because if you have hypernatremia, you got hypokalemia because they're a teeter-totter. Decreased calcium, which is where we see more osteoporosis or fragile bones, okay? And hypertension. Because what else does the adrenal glands do? ADH.
Aldosterone.
Aldosterone in the RAS system? Yeah. Okay. So treatment, you either got to take them out, adrenalectomy, which requires lifelong steroid replacement. If you take them out, it's just like when you have a thyroid removed. If you take out your thyroid, you have to take thyroid medicine for the rest of your life. You can't live without it. Well, guess what? You can't live without this either. Okay? So it is very important to know that if you take these out, they have to be on lifelong steroids. And what did we just say? That's bad. We don't want people on lifelong steroids. But guess what? I either die or I deal with the repercussions of being on lifelong steroids.
So they're making way too many steroids.
Yes.
So we take them out and then we control the amount of steroids they're getting.
Yeah.
Eventually is what's happening. Okay.
Yep. Avoid infection because we know that steroids are going to decrease our immune system. Okay. And administered chemotherapeutic agents if the adrenal tumor is present. If there's a tumor, you have to treat the tumor. Okay. Now, on the flip side, with Addison's is not enough. So we need to add. We need to add steroids. Okay. This is caused from surgical removal of both adrenal glands, infection of the adrenal glands, tuberculosis, cytomegalovirus, and bacterial infections. Okay.
So usually, in no way will you see sodium and potassium on the same direction.
You will most likely never see sodium and potassium going in the same direction. So, signs and symptoms, we have fatigue, nausea, vomiting, diarrhea, anorexia, hypotension, hypovolemia, we're confused, we have low blood sugar, basically exactly the opposite of Cushing's. Very low sodium, hyponatremia, and not a lot of volume, low water, okay? High potassium. Hyperpigmentation. This can be expressed as a bronze look to the skin. I want you to cement that in your memory. Bronze, a bronzed look. And no, they did not just come back from a tropical vacation. Okay? Vitiligo, which is white areas of depigmentation, while also seeing hyperpigmentation. Okay? So you can have both, or you can have one or the other. Okay? Every person that you see with vitiligo doesn't mean they have Addison's disease. Okay? So they are literally opposites of each other. Okay? Also, if you see someone with Addison's disease, they will put salt, an excessive amount of salt on everything. They will put salt in their water. They'll have salt tablets as medication. Okay? They will add salt to everything because they have to get it in their bodies because they don't want to be hyponatremic. Okay? Now, we talked about the Addison crisis, Addisonian, like it says here. Profound fatigue. Extreme dehydration that is causing the patient to go into hypovolemic shock. Hypovolemic, low volume. Okay? Renal failure, which comes hand in hand with hypovolemia. Okay? Vascular collapse, hypovolemia. Severe hyponatremia. We talked about hyponatremia. Confusion, fatigue, lethargy, seizures, coma, death. Hyperkalemia, arrhythmias, dysrhythmias, cardiac arrest. Okay? Just knocking on death's door. Like, hello, I'm here. Can I come in? No, you can't. You're not allowed to die. Okay? If this keeps going, your patient is on life support, 100%. Okay? The treatment is going to include fluid resuscitation, which means we're giving a lot of fluid, and high dose hydrocortisone. You can't see the treatment at the bottom. It says on the screen, administer glucocorticoid and or mineral corticoid And you want a diet high in protein and carbs. It's like the only time in your life when anybody ever tells you to eat more carbs. You have Addison's, eat more carbs. They'll give you more sugar, right? More stored glucose. Okay? Please make sure you know this. So this is just showing adrenals versus what happens when you take too much excess, like outside steroids. So your normal adrenal gland is nice and beefy and big. When you take too much of exogenous steroids, outside steroids, PO, IV, whatever, however you want to do it, you have what's called atrophy. Atrophy, you've heard of muscle atrophy, when the muscle gets smaller because it's not getting used. Well, the same thing is going to happen to your glands. Okay?
But essentially just because since you're getting it from the outside, it doesn't have to work. So it's just
when you don't use it, you lose it. Yeah, absolutely. So is it looking at the different drinks? And
Jessica, I can't. You're cutting out.
okay. Thank you. It just started, right?
Yeah.
You know, hybrid learning is hard, and then you have Wi-Fi issues. Okay, can you hear me?
Yeah.
Okay.
Yes.
All right, I just switched over, so let's see if that works. All right, so this is just looking at the different types of drugs and where they work in the body. And there's also, so this picture is on page 611, and there's also a table 36.3 that it says drugs in focus, adrenocortical agents. So, excuse me, I'd rather do that one. So if you're looking at this box, you have glucocorticoids and mineral corticoids. There are different categories of corticoids, okay? So you have your glucocorticoids, your mineral corticoids, and then your corticosteroids. I would say your most popular, of course, we have cortisone, which can be oral or oh my God, when you put it on the skin, puts the lotion on the skin. Yes, topical. Dexamethasone is very popular, oral and IV. You can give it in other ways. It can be inhaled, it can be intranasal, ophthalmic, but dexamethasone is a very popular hospital steroid. Okay. Hydrocortisone, of course, this is oral, IV, IM, topical, ophthalmic, rectal. Then you have methylprednisolone, very popular in the hospital, oral, IV, IM. Prednisolone and then prednisone, very popular. Okay. So when you're looking at all of these, I want you to look at page 613. We have contraindications and cautions. This is going to be true for like all steroids, okay? It is going to cause immune suppression, okay? It is going to suppress your immune system. So your patients are more at risk for infection every time. It is true across the board. Now, I will say, you never want to say always or never, but this is like a really strong one. It is going to cause immunosuppression, okay? In patients with diabetes, because the glucose elevating effects disrupt glucose control, the patient, is going to need more medication. If you have a diabetic that is insulin dependent, I don't care if it's type 1 or type 2, if your patient is insulin dependent and they are on steroids, they are going to require a higher dose of insulin. Okay? Because when their normal is like 250 and you're giving them 5 units, blah, whatever their order is, and then they have surgery or they have IV steroids, that normal of 250 just shot up to 350. And they're going to need more insulin. Okay? Very important concept to understand. You want to watch for patients with acute peptic ulcers because steroid use is associated with the development of ulcers and perforation. With lactation, because anti-inflammatory and immunosuppressive actions could be passed to the baby. Ooh, that's all you need is a more immunosuppressed baby. Okay. And pregnancy, especially in the first trimester, because of the potential for adverse effects on the fetus. Okay. So super important to look at your contraindications and cautions for steroids. Adverse effects, long-term steroid use in children can cause a diminished growth because it suppresses their hypothalamic pituitary system. What comes from the hypothalamus? That makes them grow. The growth hormone. So if we're suppressing their growth hormone, they're not going to grow. Okay? This is usually very important to parents. Systemic effects include hyperglycemia and the retention of sodium in water, which causes edema and weight gain. Osteoporosis or decreased bone density. So we are thinking about fall risks. Yes. My patient has osteoporosis and decreased bone density and they fall, they're going to break a hip. Peptic ulcers and infections. And we already talked about this. If you give too much, you can cause adrenal insufficiency. So we must always taper our steroids if they are administered for more than 10 to 14 days. Okay? Glucocorticoids have been known to precipitate behavioral and mood disturbances. I specifically, your girl has an anxiety disorder. I hate taking steroids. It causes me to have severe anxiety. Now, there are some people that get steroids and they feel like they are walking on water. They have a sense of euphoria. It makes them feel like they're $1,000,000. Also, it causes insomnia and they can't sleep. Okay? So you can have euphoria, insomnia, mood swings, personality changes, severe depression, and psychosis. I don't know about you, but that scares me. Okay? I hate taking steroids. So we already talked about this. This is just saying that indications for steroids could include the treatment of inflammatory disorders because it can decrease inflammation. And by decreasing inflammation, we relieve discomfort and pain. Okay. Used in conjunction with other immunosuppressant drugs to inhibit transplant rejection. This is super important. Anybody that has ever had or knows somebody that has had an organ transplant, you have to take your anti-rejection meds every single day, or you will reject that organ. So compliance is huge. And then it can be used for treatment in some cancers and other disorders and infections. So it says that it's metabolized within the liver. So if we have liver failure, we probably have to be cautious. It's excreted in the urine, so we need to make sure we have some renal function. Okay. Cautions: acute infection not controlled by antibiotics. Bad, very bad. Okay. If your patient is immune compromised, they're on long-term steroids, and they have an infection, and you put them on antibiotics and they are not responding, bad news bears, hospital. Okay. We talked about diabetes, we talked about peptic ulcers, and we talked about pregnancy and lactation. We talked about children and the diminished growth. We talked about the behavioral and mood disturbances causing adrenal insufficiency. Effects related to the route. Let's see. Additional adverse effects associated with the glucocorticoids are related to the route of administration that is used. Local use is associated with local inflammation and infection, as well as burning and stinging sensations. So if you use a steroid topically, it's going to affect that place, that local place. I mean, unless you use it every single day and it's getting systemic. So local versus systemic. Local is one place, systemic, whole body. Okay. Systemic also refers to the blood flow, like the whole body inside of the body. Okay. Drug to drug interactions. You want to be cautious with NSAIDs or alcohol. They can increase the risk of GI distress and bleeding. Concurrent use with potassium depleting agents like loop and thiazide diuretics can cause more severe hypokalemia. It can change the effectiveness of anticoagulants. So all of these drug-to-drug interactions need to be monitored very closely. Also, if I am on a steroid for the next 10 days, should I get a vaccine? No. If I'm on long-term steroids, should I be vaccinated? Yes. Yes. Okay. Unless otherwise contraindicated. So there's a difference between long-term use and short-term acute use. Okay. So we still want to make sure that our patients that are on long-term steroids are vaccinated. Okay. So this is just taking a closer look at prednisone. This is replacement therapy in adrenal cortical insufficiency, management of various inflammatory and allergic disorders. There are many indications for steroids, okay? And most, if not all, are going to be to decrease inflammation and to decrease the immune response, okay? Adverse effects include vertigo, headache, hypotension, shock, sodium and fluid retention, okay? Amenorrhea, no period, so it can disrupt your menstruation. increased appetite, weight gain, immunosuppression, aggravation or masking of infections. So it can mask the symptoms of infections, which can make your infection go septic and you don't even know it. Okay? Impaired wound healing, mood disturbances, and delirium. Glucocorticoids may be used to treat systemic or local inflammation. So what
True.
are corticoids? It's true. The treatment of inflammatory disorders and
You're cutting out again.
Can you hear me? Okay. Yes. Decrease in the formation of prostaglandins. Prostaglandins are part of the inflammatory process. And they can be used to treat local inflammation as topical agents, intranasal or inhaled agents, intra-articular injections, and ophthalmic agents. Ophthalmic in the eyes, intra-articular is in the joints. Mineral corticoids. These affect electrolyte levels and homeostasis, so you have to be very careful with your electrolytes. Aldosterone, which is a mineral corticoid, is secreted by the adrenal gland. We know that aldosterone causes sodium and water retention and excretion of potassium, which is going to put you more at risk for hypokalemia. Okay. It's not really used anymore. Okay. So we have our available mineral corticoids would be cortisone. Fludrocortisone, I don't know if I've ever actually seen that in practice. Hydrocortisone, definitely. Prednisolone, yes. Prednisone, yes. So if you look, it also says that not only is it a mineral corticoid, it also has glucocorticoid properties, which okay. So not only are they affecting your electrolytes, they're also affecting your glucose. So they increase sodium reabsorption and they increase potassium excretion, putting you at risk for hypokalemia. They are used for replacement therapy and primary and secondary adrenal insufficiency and the treatment of salt wasting adrenogenital syndrome. If you already have salt and water retention, then you definitely shouldn't use it in severe hypertension because your salt and water retention are going to cause you to be hypertensive. And then you have even more hypertension. Okay. So you're slapping hypertension on top of hypertension. Not good. Heart failure or cardiac disease. You want to be careful with high sodium intake. Okay. So you don't want these patients putting salt on everything if it's causing sodium retention. And we already talked about the infection. So the adverse effects are related to the increased fluid volume. So hypervolemia, pulmonary edema, pulmonary congestion, crackles in the lungs, peripheral edema, JVD, jugular venous distension. We already talked about the anti-diabetic medications because of the increase in glucose. Mineralocorticoids should be used with caution in a patient with which, first of all, I feel like they're all correct. Number one. Except maybe for the mild hypertension. But like, yeah. Caution is necessary in administering to people with severe hypertension, heart failure, or cardiac disease because of the resultant increased blood pressure.
I thought she said it.
I know.
Did specifically say but
It does say. What do you mean?
because she said, didn't it say that? I said, yeah, specifically.
Oh, yeah. No, I'm gonna tell you, I wouldn't put that many correct. I feel like they were all correct except for the severe or mild hypertension. I don't like that question. We got it too. Yeah. Spend the rest of the time on diabetes, then and have you guys look at this on your own time. Okay. Chapter 30. I printed 30. There's if I only brought 5 in here, so there's more on the printer. Because I printed 8 total. A lot. Yeah. It's 20 pages. Diabetes. Do you understand what diabetes is? So if you had to explain diabetes to me, how would you explain it? Type 1 or type 2? Type 1. Insulin resistance are way different. Okay, so diabetes. We talked about the keys and the locks, yes? So I eat a donut. I do not have diabetes. I eat a donut. And my body says, hey, there's a lot of sugar around here. And my pancreas says, here's some insulin made by my beta cells in my islets of Langerhans. Okay? In my pancreas. That's what they're called. Promise. Okay? And my insulin floods my bloodstream. And my insulin is my key. My glucose is my source of energy. I need glucose to go inside of my cell for ATP and energy production. Okay? So my insulin goes to the little door on my cell and it opens the door. My glucose goes in, I make energy, and I go about my day. Okay? I'm a type 1 diabetic. I eat a donut. My body says, hey, there's a lot of sugar around here. My pancreas says, okay, what do you want me to do about it? I don't have anything for you. Okay. So then we have to provide the key by subcutaneous insulin. Okay. Type 2 diabetes. I just ate a donut. I've had diabetes. I've had pre-diabetes for 10 years. I've now been diagnosed with type 2 diabetes. Okay. I've been beating up my pancreas. I've been beating it up. Not only through my lifestyle and diet, but also through my genetics. Because there is a genetic component. Okay. So I eat a donut. My blood sugar is 350. And my pancreas says, here's your insulin. And the insulin goes to the door and it goes to unlock it. But my lock is very sticky and it does not want to work. It doesn't. Some of them open, some of them don't open. Okay. So then my pancreas says, here's more. That is called insulin resistance. When some of my doors open, but some of them won't respond. That is insulin resistance. Okay. So my pancreas says, here's more. So then now I'm doubling up my keys and I can open my door. But if we don't correct the underlying process, as in lifestyle, diet, medications, then it's just going to get worse and worse and worse until my pancreas says, I'm tired. I can't do this anymore, which then becomes insulin dependent.
So a type 1, basically the pancreas don't react at all.
And type 1 diabetes is an autoimmune disease. And it's when the pancreas just stops producing insulin.
And then type 2, it reacts, but might not produce.
It reacts, but my body is resistant. So then it reacts more. And then over time, that resistance gets greater and greater. And my pancreas works harder and harder until eventually it says, I'm done. I'm not doing this anymore. And then you become insulin dependent. Okay, that makes sense?
So it's when before the pancreas says, would that be classified as the pre-diabetes that you're not there?
No. Pre-diabetes was 10 years ago.
Okay.
I've been beating up my pancreas for the last 15. Right? So this whole time, my pancreas is just taking a beating and I'm becoming more and more and more resistant. Now, this depends on the person. This could happen in 20 years. This could happen in 50 years. One of our very good friends, he died at 34 years old. Chronic kidney disease caused by uncontrolled type 2 diabetes. Lost half of his right leg before he died of kidney disease. Because diabetes ruins every part of your body. Okay? So, drugs. First of all, glucose regulation. So, hormones that are produced in the islets of Langerhans is glucagon. This is basically sugar. Insulin, which is my key. Somatostatin. We're not really going to talk. Okay? Endo meaning within. So these hormones are produced within and they stay within my system. Exocrine is outside. Outside. So sodium bicarb and pancreatic enzymes, they are not meant to be inside the circulatory system. Okay. Bile is an acid, and if it's left to just seep into your body, it will just eat away at everything. Okay. So we talked about insulin. Insulin is produced by the beta cells of the islets of Langerhans. They are released in circulation when the glucose is high. The pancreas, I went backwards. Glucagon is released from the alpha cells of the islets of Langerhans, and it's in response to low blood sugar. So if my blood sugar is low, it releases glucagon to help me increase my blood sugar. It also stimulates my liver, where my glycogen lives and my protein lives, to convert into glucose to save my life. So when we talk about drugs, the first one, the adipocytes, these are fat cells. Fat cells secrete a hormone, and that increases your insulin sensitivity. The central nervous system decreases insulin release and increases the release of stored glucose and increases fat breakdown. That means when I'm fight or flight, I don't care if you have time to eat. My body is in fight or flight and it needs to fight to live. So I am going to increase all of my stored glucose and I'm going to use it up because I need to fight. And then when I run out of that, I'm going to use my fat for energy. Okay, so that's where your sympathetic nervous system comes in. Corticosteroids, they increase your glucose release, which is why we have hyperglycemia. And then the growth hormone increases the sensitivity. So if you don't know these words, hyperglycemia, increased blood sugar. Glycosuria, this is when sugar is in the urine. Polyuria, a lot of pee, okay? A lot of urination. Polyphagia, I'm hungry. Polydipsia, I'm thirsty. Lipolysis, the destruction of fat. Lysis, destruction. Fat, this is fat breakdown. Ketosis, this is metabolism shifting to the use of fat instead of sugar for energy. Okay. And then acidosis, DAD, this is when the liver cannot remove the waste products. Okay. So when you have ketones and acid and type 1 diabetes, bad news bears, you're in DKA. Bad, bad, bad. So we already talked about this. Diabetes mellitus, this affects the metabolism of carbs, proteins, and fats. Hyperglycemia is a fasting blood sugar greater than 126 and the presence of sugar in the urine. Okay. When you have type 2 diabetes and you are hyperglycemic, you're going to see the 3 P's: polyuria, polydipsia, polyphagia. Lots of pee, lots of thirst, lots of hunger. Okay. I just said that diabetes affects every single system in your body. It will destroy every system in your body. It is not just about having high blood sugar, because it affects everything. Your eyes, your kidneys, your nerves. You can't fight infections. You're immunocompromised. You have ulcers and injuries that you cannot heal. It affects your bladder. It affects your libido. It affects your penis if you have one and causes impotence. Okay? If you can't feel things, then you're at more risk for injury. So we already said type 1 is caused by an autoimmune disorder, which is the destruction of the beta cells, so it can't produce insulin. Type 2 is the progressive loss of the beta cells. And like we said, this is the decreased insulin sensitivity, which leads to insulin resistance. Okay. So diabetes that's due to other causes, like medication-induced diabetes, like glucocorticoids. Gestational diabetes, which is diagnosed in the second or third trimester, which, by the way, is caused by the placenta. It is not your fault. Okay? There's all these girls that exercise and they eat right and they do this and they do that, and then all of a sudden they have gestational diabetes and they beat themselves up about it. It's not about you, girl. It's your placenta. She hates you. Okay? You didn't do it. So I need you to know the signs and symptoms of hyper versus hypoglycemia. Okay? Hyper, fatigue, lethargy. I'm irritated. I have glucose spilling into my urine because there's so much in my blood. My kidneys have no other choice but to put it in my urine. Polyphagia, I'm hungry. Polydipsia, I'm thirsty. Frequent infections and poor wound healing. Signs of impending dangerous complications. These are signs of decay. Fruity breath. This is caused by ketones. Dehydration. Excuse me. Your body is trying to get rid of your sugar, so you're peeing a lot. Okay? Slow, deep respirations. This is called Kussmaul respirations. When we talk about acid-base balance in a couple months, you're going to understand what that means, because it's the only way we can get rid of our acid. And then loss of orientation and coma. And then dead. I know I'm going really fast, but I don't want to miss anything. And you guys are going to have the recording anyways. So I do apologize, but I want to get through it. So hypoglycemia is a blood glucose 70 or less. The initial response is a parasympathetic stimulation. This is an increase in GI activity. Whatever I got in there, it's going to try to get through it and absorb as much glucose from my intestines as it can. Okay? Then my sympathetic nervous system is going to kick in, my fight or flight, because guess what? Hypoglycemia, dead. Okay? So it's going to break down my fat and my stored glycogen, like we talked about, to release glucose. My pancreas is going to also release glucagon to increase glucose. Okay? So my stored glucose in my liver, my glycogen, and my glucagon from my pancreas, and ketosis, which is the breakdown of fat, is going to try to increase my energy and my serum glucose, which is a clinical manifestation of hyperglycemia. See? See? So, I mean, we just went through all of these for hyperglycemia. So when we talk about drugs, there are multiple different classifications of anti-diabetic drugs. Okay. So number one, we have insulin. Chastity just reminded me that last term we had a situation where our ATI book and our pharmacology book has different numbers for the peak, onset, and duration of insulin. I need you to know your peaks, your onsets, and your duration of insulins from your ATI book. Chastity, what page is that? I don't see her, but I told her to find out while we were waiting. Anybody have their ATI book on them? Yay! Can you find it, please? Okay, so insulin. This promotes the storage of the body's fuels, facilitates the transport across the cell membrane, and stimulates the synthesis of glycogen from glucose. It helps us use sugar that is within our serum. Okay? So it is for the treatment of type 1 diabetes because we don't have any. And then it is for type 2 diabetes where my pancreas is tired and doesn't want to work. Okay. We have multiple different types of insulin. We have short acting, long acting, rapid acting, and they all have different peaks, onsets, and durations.
The endo, it's inside.
Endo is within. Yeah.
Okay, got it.
Exo is outside.
This one's real.
Page 307. Everybody write that down. Page 307 in your ATI book is your insulin peak, onset, and duration. So if I ask you, your patient just got their meal delivered, or I'm sorry, you just gave 5 units of rapid acting insulin at 7:30 a.m., at what time do I need to worry that my patient is going to be hypoglycemic? You looking at it? So my rapid, what is my onset for rapid? 15 to 30
minutes.
What is my peak?
Half an hour to 3 hours.
So 30 to however many minutes. So if I start to peak at 30 minutes and I just gave insulin at 7:30, you best believe I need to make sure my patient's okay at 8 a.m. Between 8 and 8, 9, 10, between 8 and 11, I need to make sure that my patient is okay and that they've eaten and they're not in a hypoglycemic coma. Okay. Contraindications, there is none. Okay. I don't know if I've ever seen anybody allergic to insulin. I don't think so. It is synthetic. It is very, very similar or like basically exactly the same as our insulin that we make in our bodies. Okay.
I didn't know there was such thing as inhaled.
You can inhale insulin. It is not common. Okay. You want to be cautious in pregnancy and lactation because obviously everything is different when you're pregnant and lactating. Okay. Pregnancy can cause the need for more insulin. Adverse effects, obviously, hypoglycemia. Okay. Reactions to the injection site and then decreased potassium levels. This I need you to understand. Okay. Forever and ever and ever. I don't want you to memorize this. I want you to learn it. Okay. When insulin goes into a cell, so does potassium. Potassium follows insulin.
Potassium follows insulin.
So like water.
Water follows
So
salt. Yes. Like water follows salt, potassium follows insulin. So this, my friends, is the reason why regular insulin, IV, is the treatment for hyperkalemia. Okay. So I need you to put that in your memory and remember it forever and ever and ever, because it will come up again. Drug to drug interactions. Any drug that decreases the glucose levels, obviously. We don't want more hypoglycemia. Beta blockers, why? What did we learn? What do beta blockers do to your blood sugar?
It masks hypoglycemic symptoms.
It masks. It masks your signs and symptoms of hypoglycemia. So if you take a beta blocker, you're hypoglycemic, you don't realize it, you have no signs or symptoms, and then you take insulin on top of it and become even more hypoglycemic. Hello, coma.
Part of my loan.
Okay. Thiazide diuretics are glucocorticoids because they raise the blood sugar. Possible interactions with various herbal therapies. You want to be very careful with supplemental herbal things that you can buy like at Walmart in the drug aisle. So, like I said, this is different than what's in your ATI book. I want you to learn your ATI book because that's what you're being proctored on. Okay? Was it 307 or 305? One of those numbers.
307.
307. All right, sulfonylureas. These stimulate the functioning beta cells in the pancreas to release insulin. So it helps the pancreas release more insulin. It improves insulin binding, so it helps that resistance. It increases the antidiuretic hormone. So we're not peeing everything out. It's only effective in patients that have functioning beta cells. So it is not a treatment for type 1 diabetes. No, no, no. They can lose effectiveness over time. And we have first generation and second generation sulfonylureas. The second ones are better than the first. And these are listed on page 657 in table 38.1. I would say so. Yes. So they stimulate insulin release. We already said that. They improve the binding of insulin. So they improve the way that the key unlocks the door. That helps my door be less sticky. It is used in adjunct to diet and exercise. And it can be used adjunct to insulin and metformin to improve glucose control. So we can combine our anti-diabetic drugs. Most of these, if not all, are going to be excreted in the urine. So we need to make sure that our kidneys are functioning. Glyburide is also excreted in the bile. It is contraindicated. Sulfonylureas are contraindicated in type 1 diabetes and pregnancy. So your second generation sulfonylureas are glipizide. That's going to be your most common. Okay. Adverse effects, of course, is going to be hypoglycemia, GI distress, allergic skin reactions. We want to be careful with beta blockers because of the masking of hypoglycemia, alcohol, and other herbal therapies.
In this table, it has the first generation, second, then it has like the alpha glucose, the days.
We haven't got there yet.
Okay.
Okay, so next we have glucose inhibitors, and these break down the excess glucose for absorption. It delays the absorption, which helps lower our A1C. How long does A1C test over? Is it 1 day? 3 days?
3 months.
3 months.
3 months. It takes your average blood sugar over a 3-month period. So if you have been a non-compliant diabetic for 2.5 months and then decide for 2 weeks before you go see your doctor, you're going to tighten it up, it's not going to work because it's the average over 3 months. Okay. So if I say that you have an A1C of 9, are you compliant? No. No. What is the goal A1C for a patient with type 2 diabetes? The goal. Less than 7. Okay. So 6 for type 2 diabetes, your goal A1C is less than 7. Okay. These can be used in combination with other drugs. And this is the most common one. Actually, I don't know if I've ever seen either of these. Archibos and Miglitol, maybe Miglitol. So the next one is going to be your biguanides. This is your metformin. Okay. This is your most commonly prescribed medication, probably in the US. So, metformin, which is a biguanide, decreases production and increases uptake of glucose. It lowers both basal and postprandial. Basal, meaning this is my base. This is the normal amount of insulin that my body needs to function without anything else. Postprandial means after meals. Okay. It decreases the hepatic glucose, which is your glycogen, and it improves the sensitivity, which decreases the resistance. This is the first line drug for people with type 2 diabetes. It is contraindicated with patients that are experiencing metabolic acidosis and severe renal impairment because it is excreted in the urine. You want to be cautious with hepatic impairment, no excessive alcohol intake, patients not eating or drinking due to surgery, patients undergoing radiologic studies with contrast. If your patient needs a CT scan with contrast, you have to hold the metformin for 24 hours before and 24 hours after, for a total of 48 hours. Very important. Adverse effects. This can cause lactic acidosis, which is why metabolic acidosis is a contraindication. If I'm already acidotic and it causes more acidosis, I don't want both. That will kill me. Don't like that. GI effects. If you've ever taken metformin, you know that it makes you poop your brains out. I've never done it, but I've heard a lot about it. Dizziness, headache, upper respiratory infections, and taste disturbance. Also, rhabdomyolysis. Put that on your paper. Rhabdomyolysis. All right, this DPP4 inhibitors, this is your, the only one that I recognize is the Januvia. I can't say the other name. It starts with an S. Sitagliptin. Januvia, I feel like we've all seen that on commercials. Okay. This increases your insulin release, lowers your glucagon secretion. It's used for type 2 diabetes. I believe it's a once weekly injection. It is contraindicated in DKA or type 1 diabetes. It is excreted via the kidneys, so you must have renal function. So rare pancreatitis. Pancreatitis is extremely painful. It's very, very, very painful. Okay. Megalodota, however you say that word. These are not super common. The names are also difficult to say. And they end in tinites. So they're similar to sulfonylureas, extensively metabolized by the liver, quickly eliminated by the kidneys. So I would say it's contraindicated in hepatic impairment. This is contraindicated in type 1 diabetes or DKA. No breastfeeding. SGLT2, Farxiga, dapagliflozin, and Jardiance, which is empagliflozin. Those are I don't like those words. Okay. They block the co-transporter system, so glucose is not reabsorbed but lost in the urine. So if you're taking this drug, you could assume that you would have high amounts of glucose in the urine. Okay. Contraindicated in DKA or type 1, we're seeing a trend here. Okay. Contraindicated in severe renal impairment. Adverse effects include dehydration, hypotension, UTIs, and fungal infections because of the increase of glucose in the urine. Guess who loves sugar? Bacteria and yeast. Ooh. Love sugar. Okay. Can cause DKA. Can cause you to have a limb amputated, and that's not fun. This classification, these are not common drugs, but they do decrease the insulin resistance and increase the responsiveness to insulin. They're contraindicated in moderate or severe heart failure. You want to monitor for any changes in liver function because it can cause hepatic injury. Human amylin. This is a subcutaneously injected drug, and it can slow gastric emptying. It suppresses glucagon secretion from the liver, regulates food intake. Patients with both type 1 and type 2 who are also treated with insulin. That's a first. That's a zebra. Can be used for both. It should be injected before each meal. Can you mix insulins? Some of them. Which ones? NPH? You can only mix your rapid and NPH. Okay? NPH and rapid are the only ones that can be mixed. You remember? Clear, cloudy, cloudy, clear.
Yeah, okay.
This is injected before each meal. Can this be mixed with insulin? Abso-darn-tootly not. No way, no how. Very bad. Don't do that. So on the previous slide, it said that it slowed gastric emptying. It is contraindicated in patients that have gastroparesis. Gastroparesis is the paralysis of the stomach, where you don't have peristalsis, the movement that you need to churn the food around and digest the food. So if you already have that, you don't want to give a drug that is going to slow your gastric emptying. Severe hypoglycemia is an adverse effect. It can be given in combination with insulin, but you better be very careful. Very, very careful. GLP-1s, these are all the rage. It's your semaglutide and tirzepatide. Semaglutide is Ozempic, tirzepatide is your Mounjaro. These increase insulin release, decrease glucagon release, and slow GI emptying. This is a huge risk factor for gastroparesis and acute pancreatitis.
Is that why we
Yes, that's why when you take these drugs, you do not want to eat. And you feel full for very long because the food literally just sits there. Yeah. So this can be used in adjunct to diet and exercise, and it has shown that it has decreased the risk of major cardiovascular events. These are usually administered once weekly through a sub-Q injection. If you've ever considered taking semaglutide, you would know that they ask you about thyroid cancer because semaglutide can put you at a higher risk of developing thyroid cancer. So if you have a history or family history of thyroid cancer, you should not be taking it. Don't take it in type 1 diabetes or DKA, and it is not to be taken during pregnancy and breastfeeding. I told you pancreatitis is a huge adverse effect. And again, pancreatitis is extremely painful. You must stop taking the drug if you have pancreatitis. I know it's 2:06. If you have to go, you can go. I'm going to keep going until 2:30 when people have to take their math test. Okay. So you guys don't have to stay, go. I'm just going to keep going. So glucose elevating agents, these are the drugs that are going to treat hypoglycemia. So if you have a hypoglycemic episode and we need to treat you, number one, are you conscious? Okay. So I am having a hypoglycemic episode. My blood sugar is 52. You walk in my room, I am arousable. I can follow direction. I'm alert and oriented. What are you giving me? Juice. 4 ounces of juice, which equals 15 carbohydrates. They're fast acting. Okay? It's instant sugar. If I am not conscious and I'm not talking to you, what can you give me? Glucagon. I am glucagon. You can give me glucagon in my mouth, like the gel, glucagon gel. Okay. And then if I'm severely hypoglycemic, non-responsive, what are you giving me? IV dextrose.
D5.
IV dextrose. You're not responding. What else? And it's not. Yeah, it is. It's basically pure syrup, and it's very hard to push. It's like literally pushing sludge, and you're like giving it all you have while you're trying to push it. It's very difficult. D50. So when we're talking about treating hypoglycemia, if your patient is arousable and oriented, you are going to give juice. 4 ounces of juice. And how long are you going to wait to recheck? 15 minutes. If your patient is severely hypoglycemic and you're giving D50, are you waiting 15 minutes? I'm waiting 5. I'm waiting 5. Okay. So since when it looks closer at the medication, the onset IV glucagon is 1 minute and the peak is 15 minutes. So you should absolutely see your patient's blood sugar go up within that period of time. If you give juice and then your patient becomes more unresponsive, the juice is not cutting it and we need to give something else. Okay. Questions? Chapter 38. Who needs to take their math test? Okay. Anybody else? Okay. Any questions, guys? So remember, do not forget to go over chapter 37. Do not forget that. Okay? Next is Tuesday. I will send out key points. I will try to do it tomorrow. I might need a a gentle nudge, because the funeral is Saturday. So I might need a little gentle nudge, for key points. Don't be blowing me up. Okay. And when you send it, hit reply all so everybody knows that you did it, so I don't get 50 people reminding me about key points. Can you do that for me?
Nope, I'm all
right.
good.
Any of my friends that are still on, do you guys have any questions for me? Do you need me? Okay, everybody's good. All right, so this is a
Nope, I'm good. Are you able to please upload the video or no? Our classes? I know you're
the
busy.
last class?
Yes.
Oh, I thought I did that. Oh,
Oh,
I
I
did it
didn't.
on YouTube. I did it on YouTube, but I didn't put it on Brightspace.
Please.
Do that right now.
Thank
Anybody
you.
else?
I have a question, Ms. Simmons. Is there any way to get today's lectures video before it's uploaded to YouTube? I like to rewatch and take notes when my kids are quiet.
Amen. Amen. So here's the problem. Ring Central takes forever to process it. And that is where the problem lies, because I have to wait until Ring Central tells me that it has it available for me. And
Okay, that's fine. I'll just keep.
So hopefully it will be available to me. How long is this video? How long have we been on here? 4.5 hours. It'll probably take at least 3 to 5 hours for it to be processed, for it to tell me that I'm allowed to download it.
Gotcha. Okay, thanks. I'll just stalk the YouTube. Thank you.
Yeah. I am going to post Tuesday's video right now in week 2. Thank you guys. Thank you guys so much.
Yes, good luck and have a great rest of your day.
Good luck with everything.
Thank you. Thank you. You guys too.
Alrighty.
And let me know if you have any questions, okay? I am posting this to Brightspace right this very second.
Hey, Jess.
Yeah.
Did you see